For the last few slides, I will quickly focus on how this tumor evolution can be possible from one of our study that we presented at ASCO 2024 as well as at ASCO GU as well. Again, this data is coming from prostate cancer, but can be utilized for lung cancer as well. In this study, we utilized and we looked into ctDNA collection pre and post treatment when the same patient had received ctDNA testing within 3 months of treatment discontinuation. So those who had pre-treatment testing as well as those who had ctDNA testing 3 months within the treatment discontinuation. And we looked into various, like three particular groups. One was RPs, which is androgen receptor modulators, PARP inhibitors, which are again those patients who have different kind of BRCA or similar mutations. And the third ones were taxanes, which are the chemotherapy utilized in various different solid tumors as well. And what we saw was, if you can just look over here at the orange colored portion of the bar graph, is that this all were newly detected mutations after PARP inhibitors, which can sometimes be used in the non-small cell lung cancer as well as taxanes chemotherapy, which can be used in non-small cell lung cancer as well. What I want to show with these two figures is that it helped us evaluate that based on this treatment, prostate cancer can evolve and have different alterations as well. And this could be possible in non-small cell lung cancer too. We also looked into overall survival based on ctDNA burden, and it showed that patients who had higher ctDNA burden had lower survival. And therefore, again, showcasing that it can help us risk stratify the cases too. So with all of this, you would ask that how do we currently approach doing this NGS testing? What simple approach right now is when a patient is diagnosed with cancer, especially non-small cell lung cancer, NGS testing should be conducted. First of all, in tissue for sure, and along with that, if possible, in liquid biopsy as well. This will give us available idea about actionable alterations, which is biomarkers which can have targeted therapies. There can sometimes be alteration identified just in tissue biopsy. Sometimes it can be just identified in liquid biopsy. Therefore, doing both is going to be extremely helpful. In some cases, when they have significant family history, we certainly send the patients for genetic counseling as well and germline testing, which means hereditary genomic alterations can be evaluated as well. When the patient is started on treatment, liquid biopsy can be helpful to evaluate treatment responses and minimal residual disease, as we showed in the case number 2. And then again, upon progression, it is very helpful to, if possible, do tissue biopsy if the tissue location is available. And along with that, also do liquid biopsy. And so here in the last slides, I want to show phase 1 tumor boards. Whenever there is such different alterations that you saw, co-mutations when there are more than 1 or 2 mutations that are happening, or understanding what kind of resistance mechanism could be developed, or evaluating if there's novel treatments which are possible, all this can be discussed in this molecular tumor boards as well as phase 1 tumor boards as well. And it can guide physicians, medical oncologists on what kind of patient sequencing can be done, as we saw in the phase and in the case 1, that depending on the frontline treatment, various different treatment options can be given, as well as it can help in decision making for those patients who have progressed on multiple lines as well.